Hi, my name is Nasser. I'm the pharmacy director here at KVH. And this is Rex. He's from Creighton University. He's a doctor of pharmacy candidate for 2015. We're going to be talking about the medications in stroke, some of the medications involved in stroke. And as we go through the slides, Rex is going to take over.
Okay, thank you. Again, my name is Rex, and we're going to be looking at some of the medication that are used for treatment of stroke. Most of the information that we're going to be presenting may have been covered by Dr. Tikesh and Melinda Carter. So there's going to be some repetition, but I think that will be okay as well. Okay, this is just what tPA does in terms of helping somebody recover from stroke or prevent stroke. Essentially, we see what's going to happen here. The blood clot stops blood from flowing into the arteries. And here we see what is going on. The tPA comes and attacks or dissolves the blood clot, and blood starts flowing back. And this is just a handout for completeness sake. We're going to show you a video of what is going on, how the tPA actually goes to dissolve the blood clots. And
Activase, also known as recombinant tissue plasminogen activator, or tPA, is the only drug approved by the FDA for treatment of stroke. Growing plaque can rupture, promoting thrombus formation by activating the coagulation cascade. Platelets and red blood cells aggregate at the site of injury, causing further narrowing of the artery. This impedes blood flow even more and causes turbulence in the artery. It also increases the likelihood of thrombus formation. As the thrombus grows, it causes increased vessel narrowing, leading to partial or even complete occlusion. The occluded artery leads to ischemia and tissue necrosis. When a piece of thrombus breaks off, it's called an embolus as it travels up the artery. During a stroke, ischemia can progress to infarction. Beyond the infarction lies still viable tissue called the penumbra. Cells within the penumbra are potentially salvageable if blood flow and vital oxygen are restored promptly. The penumbra is the focus of fibrinolytic treatment. Now let's look at the thrombus itself. Inside the thrombus are strands of fibrin, the protein that forms a clot. Enmeshed within the fibrin is plasminogen, the inactive precursor of plasmin. Activase is administered by IV infusion within 3 hours of acute ischemic stroke symptom onset. Activase binds to the fibrin in a thrombus and converts plasminogen to plasmin. Plasmin then breaks the strands of fibrin and dissolves the clot. As the clot dissolves, blood flow is restored, and viable tissue may be reperfused. Although the original infarction remains, when surrounding cells in the penumbra are saved or reperfused, function may be restored. Activase, the one tPA for stroke, is the only drug approved by the FDA for this indication. Activase is indicated for the management of acute ischemic stroke in adults for improving neurological recovery and reducing the incidence of disability. Treatment should only be initiated within 3 hours after the onset of stroke symptoms and after exclusion of intracranial hemorrhage by a cranial computerized tomography, CT scan, or other diagnostic imaging method sensitive for the presence of hemorrhage. See contraindications in the full prescribing information. All thrombolytic agents increase the risk of bleeding, including intracranial bleeding, and should be used only in appropriate patients. Not all patients with acute ischemic stroke will be eligible for Activase therapy, including patients with evidence of recent or active bleeding, recent within 3 months intracranial or intraspinal surgery, serious head trauma, or previous stroke, uncontrolled high blood pressure, or impaired blood clotting. For further information, please refer to the full prescribing information accompanying this video animation.
so what we'd like to show you now is how to administer the Activase how to reconstitute it before you administer it to the patient.
Treatment with Activase includes reconstitution, dosing, and administration. While Activase comes in vials of 50 milligrams and 100 milligrams, the 100 milligram vial is most commonly used. Activase should be reconstituted immediately before use and only by aseptically adding sterile water for injection USP without preservatives. This preparation will result in a colorless to pale yellow transparent solution containing Activase 1 milligram per milliliter. Activase may be administered as reconstituted at 1 milligram per milliliter. As an alternative, the reconstituted solution may be diluted further immediately before administration in an equal volume of 0.9% sodium chloride injection USP or 5% dextrose injection USP to yield a concentration of 0.5 milligrams per milliliter. When diluting, either polyvinyl chloride bags or glass vials are acceptable. The vial should be reconstituted by using the transfer device provided and adding the contents of the 100 milligram vial of sterile water for injection to the contents of the 100 milligram Activase powder. Mix with a gentle swirl or slow inversion. Slight foaming upon reconstitution is not unusual. Allowing the solution to stand undisturbed for several minutes is usually sufficient to allow any large bubbles to dissipate. Before administration, the Activase solution should be visually inspected for particulate matter and discoloration. The dose may be calculated as soon as a patient's weight is determined in order to expedite administration. To calculate a patient's dose, you can refer to the Activase dosing slide calculator. When administering intravenous Activase for acute ischemic stroke, the recommended dose is 0.9 milligrams per kilogram, and the total dose should not exceed 90 milligrams. Treatment should be infused over 60 minutes, with 10% of the total dose administered as an initial intravenous bolus over 1 minute. Let's walk through an example of how to calculate Activase dosing for a patient weighing 180 pounds. Using the Activase dosing slide calculator, the total dose is easily determined to be 73.6 milligrams or milliliter equivalents. Remember that Activase has been reconstituted to 1 milligram per milliliter. Starting at the right, note that the unused quantity is 26.4 milliliters. You may draw this quantity out of the 100 milligram vial before administration using a syringe and discard it to safeguard against any errors in dosing. The bolus dose is 10% of the total Activase dose, or 7.4 milliliters for a patient weighing 180 pounds. The infusion dose for a patient weighing 180 pounds is 66.2 milliliters. This is 90% of the total dose. It is also the amount of solution remaining in the 100 milliliter vial after removal of the excess solution and bolus dose. The bolus dose may be prepared using one of the following methods. The first is to remove the appropriate volume from the vial of reconstituted Activase using a syringe and needle. Activase can also be administered by programming an infusion pump to deliver the appropriate volume as a bolus at the initiation of the infusion. When preparing the bolus dose or drawing off excess solution, be sure to insert the needle into the peripheral area of the vial top, away from the puncture site caused by the transfer device. The remainder of the Activase dose may be administered by inserting the spike end of an infusion set through the same puncture site created by the transfer device in the stopper of the vial of reconstituted Activase. The vial may then be hung from the plastic molded capping attached to the bottom. If your hospital uses 50 milligram vials, reconstitution should be carried out using a large bore needle and syringe, directing the stream of sterile water for injection USP into the lyophilized cake. Do not use if vacuum is not present. Slight foaming upon reconstitution is not unusual. Standing undisturbed for several minutes is usually sufficient to allow dissipation of large bubbles. The syringe should not be primed with air during preparation and should be inserted into the Activase vial stopper. The remainder of the 50 milligram dose may be administered using a polyvinyl chloride bag or glass vial and infusion set. No medication should be added to infusion solutions that contain Activase. For specifics regarding dosing and administration, please see the Activase full prescribing information. Once Activase has been administered, it is recommended that any sudden worsening of neurologic symptoms should be reported to the physician for anticipation of a repeat head CT to rule out hemorrhage. Monitor the patient closely for any signs and symptoms of bleeding and report findings to a physician immediately. For a comprehensive list, please refer to the AHA-ASA guidelines for the treatment of acute ischemic stroke in adults.
Our nursing supervisors or physicians don't have to be worried about learning or remembering all of that. That's a very large benefit for a small community like ours to have a 24-hour pharmacy. We prefer to use the method that we give you the 10% dose on a separate syringe to avoid any errors. Some hospitals prefer to put everything in a bag and just, like you saw in the pump program, do the 10%, but leaves a very large error potential there. So we do the two process syringes there, and when the stroke is called, then pharmacists will go to the ER and keep an eye to see what's happening there, so we can gauge if we're gonna need the tPA prepared or not. As you see, it takes a little bit of time. It's not something I just squirt water in there and away you go in 30 seconds. It takes a little bit of time, so we want to be prepared and ahead of time to have that ready. And besides, as you're gonna see later on, it's a pretty spendy little bottle, so we don't want to make a mistake on that one.
So these are the criteria for people that qualify for ATPA medication. And this is according to the American Heart Association and the American Stroke Association 2013 guidelines. And we have seen some of these guidelines before, and they were covered in the previous presentations. I just want to draw attention to the fact that there are some. This is a newer thing that has come up, as was indicated previously. Again, there are some benefits that could be derived from administering tPA between 3 and 4.5 hours if the patient meets these criteria. They're less than 80 years of age. Their score, NIHSS score, is less than 25, and all this other stuff. They can also benefit from tPA. Excuse me. And these are some of the criteria they need to meet as well. Okay. tPA is the only approved product that we can find in the market right now, but there is another product that it's also used for for AMI. It's approved for AMI by FDA. But this study, the ASCESS study 2, was trying to compare both of them to see the efficacy and safety of the two products, and they both are equal in efficacy. But this particular drug, Tenecteplase, tend to have some advantages, and the advantages you can see if we go down the list over here. It tends to have less bleeding, intracranial bleeding. So in terms of safety, it tends to have an edge over Alteplase. Also, it's administered only once. While this, you have to do the bolus 10% bolus, and then the 90% administered over 60 minutes. This is done over 5 minutes, and it's 50 milligram. You cannot go above 50 milligram, while with this you cannot go above 90 milligram. And the cost of Activase, it's about, well,
that's the KVH price.
KVH price is about 7,000, and the retail whole price is about $9,000. And at present, KVH does not carry this, so we do not have a price for it. But this is a retail price for this. So if we're going to use 50 milligram and going to achieve the same effect as Activase, there seems to be a reason to start to consider this for an application. But currently, this is what we have in-house. And we're going to ship our presentation to Anticoagulants. And these are some of the traditional anticoagulants that we're very familiar with. The warfarin, the heparin, and the low molecular weight heparin. And the gray indication shows the factors that they do act on. For instance, the warfarin acts on factor 2, factor 7, factor 9, and factor 10. But we do have the new anticoagulants that are presently in the market, and Dr. Takesh mentioned them. One of the advantages is that you don't have to keep monitoring the INR constantly. And so those present some advantages over the traditional anticoagulants. So let's look at some of this. So we have we've kind of narrowed it to oral anticoagulants. So we're looking at warfarin and comparing them to the recent or to the new anticoagulants. And in-house we do have warfarin and Xarelto, and we do not carry these two. But in terms of effectiveness or in terms of benefit, they're all comparable to warfarin, and in terms of effectiveness and rate, though warfarin or Coumadin, you still have to monitor it constantly. And in case of a stroke, this is actually, you have to bring this on board with intravenous heparin, okay, together with this. So, but we're just looking at what happens after the effect in terms of oral usage. And you can see they have identical benefit, but there is a difference in terms of price or in terms of cost.
At Super One, the warfarin costs 35 cents for our copay, and the Xarelto is 75. So there is a pretty good insurance benefit, but it is still a huge difference.
Okay. Thank you for pointing that out. These prices I have here does not look at the insurance co-benefit. This is just retail prices without the co-pays. Okay. So over here you can see that warfarin, in terms of cost, has the advantage. And part of the side effect that has been mentioned in the presentations for the anticoagulants and for tPA has been the question of bleeding. Okay, what do we do for bleeding? And so here we're looking at how do we manage bleeding. And for warfarin, everybody knows that well, not everybody, I think everybody knows we use vitamin K, as an antidote, and we use K Central for controlling bleeding for the other newer agents. And there are some other agents, antidotes, that are under development, And we can see that this one here, actually, this particular one here works for both low molecular weight heparin, unfractionated heparin, and the new anticoagulants. Okay, so for the newer anticoagulants, how do you dose them? If we dose them pre-treatment INR. So if the pre-treatment INR is between 2 and less than 4, we dose 0 to 25 units per kilogram of the patient's weight. And we cannot exceed 2,500 units for the patient. Okay. And if the INR is between 4 and 6, and we dose according to this protocol, and it's greater than 6, and we dose according to this protocol, and we do not exceed 5,000 units. Okay, so that's how we dose it. But the disadvantages of this is bleeding. If this is bleeding, this drugs goes this direction, and so you are coagulating the blood, and you could actually cause clots, and that's one of the side effects of these medications. Aspirin therapy. We're looking at how do we use aspirin to prevent stroke, or to prevent the reoccurrence of stroke. And here based on studies that have been done, it appears that the combination of aspirin and Plasminogen, if given within 24 hours of onset of symptoms of stroke, can reduce the risk of stroke during the first 90 days post the event. Bleeding risk is not increased with the combination of aspirin and Plasminogen. Okay, and so it looks like from the studies that have been done, it looks like the combination is only effective for about 3 months. Beyond that, you don't get any benefits. All right, so you can go alone. After 3 months, you could go alone with aspirin. If the person or the patient cannot tolerate aspirin, then maybe Plasminogen will be an option, an alternative. The other stuff that hits the market is Aggrenox. Okay, that, according to studies that have looked at antiplatelet therapy, they think that in terms of ranking, aspirin is the best medication based on efficacy and price and cost, and then Aggrenox comes second, and that's then the third is Plasminogen in terms of ranking. Okay. For this application, we use it for TIA or minor stroke. In this slide, we kind of define what minor stroke is. If it has a score of less than 3, then it's categorized as minor stroke. And Dr. Takesh has explained what ABCD D squared means. The score can go from 0 to 10. And this is just how you get the different scores. Okay, so if your person is less than age 60, they get no points. If they're older than 60, they get 1 point. If their blood pressure is raised above 140/90, they get 1 point. And if they have unilateral weakness, then 2 points. And if the duration of stroke is greater than 60 minutes, and they get 2 points as well. So the combination will give you 0 to 7 points. And as he suggested, anything greater than 4 it's a candidate for needs admission. And these are some of these risk categories. Okay. What I have here is the recommendation of the different association on the use of aspirin. And so ACC stands for American College of Cardiology, ACCP, American College of Chest Physicians. And so these are some of the things they are recommending for the use of aspirin therapy. Prevention of stroke in women. The American Heart Association recommend 81 milligram once daily. To prevent stroke due to arterial fibrillation, they suggest, some of these organizations suggest 75 to 325 milligram once daily, 75 to 325 milligram daily, and those agree with each other. And so for the different incidents, they have their different recommendations. And that's all we have for you today. I don't know if you guys have any questions for us. Thank you.